start. Welcome, everybody. My name is Laurent Brochard from Toronto, and I'm one of the 3 editors of the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, who are going to present to you specifically tonight the special issue of critical care. You know, the Blue Journal is publishing pulmonary science and critical care. And twice a year, we do a special issue dedicated only to critical care. And we just released this, the March 1st issue a few days ago. And we thought it was a good opportunity to show you the content, which I think is really exciting in terms of science. And we separated in 3 parts. If I'm correct, I see that the first part will be by Leo Hunks, who will present about mechanical ventilation.
Thank you very much.
I forgot to say about the issues.
Oh, yeah. So for everyone who's interested, there's copies of the issue right here, so you can read it maybe tonight or in the weekend. So I would like to highlight 3 papers that were published in the special issue on mechanical ventilation. So these are my disclosures. I don't think there's anything related to this presentation. The only thing is, obviously, that I'm associate editor of the journal. So the first trial I would like to discuss is the VENT-AVOID trial. And the rationale right here is that, as we all know, hypercapnic acidosis is a key feature for acute exacerbation of COPD. And persistent hypercapnic acidosis is one of the reasons for NIV failure. And on the other hand, in patients already invasively ventilated, persistent hypercapnia may be a reason for difficult weaning. So from a physiological perspective, extracorporeal CO2 removal may, on the one hand, in these patients, avoid intubation, or in patients already intubated, may facilitate early extubation. So in this multi-center, 2-strata, randomized trial, they evaluated the effect of extracorporeal CO2 removal to avoid intubation or facilitate extubation during acute exacerbation of COPD. And their hypothesis was that compared to standard of care, ECOR would increase the number of ventilator-free days in patients with acute exacerbation of COPD failing NIV, at risk of failing NIV, or difficult weaning from invasive ventilation. So as I mentioned, there are 2 strata. The first stratum, NIV patients at least for 1 hour on non-invasive ventilation, and at high risk for failing, for invasive mechanical ventilation. So these were patients with either a pH below 7.25 despite non-invasive ventilation, no improvement of arterial pH under NIV with severe dyspnea, patients with tachypnea higher than 30 per minute, or intolerance of NIV with acidosis and dyspnea. So that's stratum 1. The second strata with difficult weaning patients invasively ventilated for less than 5 days, and the patients failed an SBT or were deemed not suitable for SBT or extubation. So it was standard of care versus ECOR, low flow ECOR. In this study, around 500 ml per minute of blood flow, and the primary endpoint was the number of invasive ventilator-free days within the first 5 days after randomization. And it should be mentioned that the trial was discontinued early because of slow recruitment. So they calculated 180 patients, but finally 110 were recruited. So it looked like that. A large number of patients, almost 6,000 patients were screened, but finally 113 patients were randomized. 48 patients in the NIV stratum, 65 patients in the IMV stratum. Just a few highlights on patient characteristics. For the NIV failing stratum, typical patients somewhere between 60 and 70 years of age, BMI around 30, dyspnea score really high, but not significant different between the groups, arterial PI, obviously acidosis, pH around 730, and they were on non-invasive ventilation for approximately 0.5 days. The IMV stratum, also around 60, 65 years of age, BMI 28, 26, high levels of dyspnea, pH of 736, 740, and they were on invasive ventilation for approximately 1 day. Again, no significant difference in baseline characteristics. And this is the primary endpoint. Ventilator-free days at 5 days for the NIV stratum. No significant difference between standard of care or ECOR. But you need to highlight this. I think this was a little bit disappointing maybe for the authors, that only one patient in a NIV group was intubated. So then it's really hard, of course, to make a difference. Primary endpoint for the IMV, invasive stratum, also no significant difference. 2 days for the ECOR group and 0.25 days for the standard of care group, but there was no significant difference. Secondary endpoint, I'm going to review a couple. So time to ICU discharge, significantly higher for the NIV stratum in the patients randomized to ECOR as compared to the standard of care, but no significant difference in the invasive mechanical ventilation group. And this is always important, has been discussed in a session yesterday, or the day before yesterday actually, severe adverse events with low flow, extracorporeal CO2 removal, no significant difference between the groups, neither for the NIV stratum nor for the invasively ventilated patients. And right here you'll see the number of patients with bleeding events, not different, but the important thing here is there was no single case of intracranial hemorrhage. One other secondary endpoint, survival. Survival tended to be lower in the NIV ECOR group, and there was one death that was definitely related to extracorporeal CO2 removal. But of course we have to be very, very careful. This is a secondary endpoint and the study was not powered for that. And for the IMV stratum, there was no significant difference in survival. So how would I interpret this study? I think it's a very important and timely study. It's the largest clinical study for extracorporeal CO2 removal in patients with acute exacerbation of COPD or COPD overlap with asthma. I think we can safely conclude now that at this time there appears to be no role for ECOR to prevent intubation in patients with acute exacerbation of COPD on NIV. And I don't think that at this time there is a role for ECHO to facilitate extubation in these patients. The second study I would like to discuss is a very interesting study as well that focuses on the transition from the OR to the ICU. So it's a study with senior author Schaefer, Darrow van Wezel as the first author, as you can see right here. And the rationale is, as you all know, lung protective ventilation is a standard of care for patients with and without ARDS, right? But observational studies demonstrate that low tidal volume ventilation is more prevalent in ICU as compared to OR settings. And it's frequent ventilator adjustments during the transition from OR to the ICU. So the aim of this study was to characterize ventilator adjustments upon the transition from the OR to the ICU. So this is a registry study in patients with elective or emergency non-cardiac surgery. So they had to be admitted, obviously, to the ICU directly from the OR and had been ventilated in the OR for at least an hour. Primary exposure changes in difference in mechanical power upon the transition, and the primary outcome was 28-day mortality. And this is already interesting. So it shows the changes in, for instance, tidal volume during the study period. As you can see, both in the OR and in the ICU patients, tidal volume decreased during the study period. Also, driving pressure decreased, but respiratory rate, both in the OR patients and in the ICU patients, increased, with respiratory rate being higher in the ICU patients. So this is the transition. Right here you'll see. So this is the OR period, this is the ICU period. Tidal volume. At the time the patients entered the ICU, tidal volume was immediately reduced. Respiratory rate, as shown right here, upon transition into the ICU, immediately increased. And it's a large group of patients, right? 2,100 patients. So right here, it shows the changes in ventilator settings, for tidal volume, for driving pressure. So respiratory rate increased and mechanical power slightly increased as well upon transition to the ICU. So right here, the association with 28-day mortality. So the change in tidal volume was not associated with mortality. The associations with mortality were the change in mechanical power, the increase in mechanical power, or increase in respiratory rate. So right here, it shows in blue, I want you to focus on the blue, it shows the adjusted risk of 28-day mortality at different levels of change in mechanical power. So for instance, in a patient where mechanical power did not change upon transition, mortality was 9%. However, if mechanical power increased by 5 joules per minute upon transition, mortality was 4% higher, 13%. So how I would interpret this study, I think it shows that the larger the change in mechanical power, the higher the mortality, which is mainly explained by changes in respiratory rate. And of course, I can see you thinking, well, this has to do with how sick the patients are. I think they did a very robust analysis with a variety of sensitivity analysis, but it would take me an hour to explain it right here and only have like a few minutes. But of course, it is observational data and there is a risk for residual confounding. And finally, a very nice clinical physiological study. As we all know, it's from senior authors Marcello Amato, Giacomo Bellani. Neuromuscular blockers are frequently used in patients with ARDS to facilitate lung protective ventilation. With diaphragm inactivity, there's a good control of tidal volume, it prevents Pendelluft, so it may be part of lung protective ventilation. But the impact of neuromuscular blockers on expiratory muscles is unknown. And why is that important? Very briefly, as you know, that recruitment of the expiratory muscles increases abdominal pressure, increases expiratory flow, and therefore will decrease end-expiratory lung volume. Activation of the expiratory muscles decreased end-expiratory lung volume. So it's a kind of anti-PEEP effect. So in this study, what the authors did is a prospective observational study in 2 ICUs. And the aims were, 1, to study the effect of neuromuscular blockers on end-expiratory lung volume and clinical factors that were associated with the effects of neuromuscular blockers on end-expiratory lung volume. And I have to warn you, I say end-expiratory lung volume to make it maybe easier to understand, but in fact, it's end-expiratory lung index as assessed with EIT. So these were patients with ARDS already on neuromuscular blockers with a kind of NMBA holiday to prevent accumulation. So there was a short period without neuromuscular blockers. At that time, they did EIT, esophageal pressure measurements, at the time of the NMBA holiday, and when neuromuscular blockers were restarted. And for the study, responders were defined as these patients where the changes in end-expiratory lung volume were higher than 10% of the changes in tidal volume. 46 patients were recruited, PF ratio 165, and 50% of the patients were responders. And this might be a quite complex picture, but I get you through. So right here, it shows the platysmogram as generated with EIT, but now I'm just, again, going to just say tidal volume. So inspiration, expiration during assisted breathing. Now neuromuscular blockers are introduced, and as you can see, expiration is incomplete. So and expiratory lung volume actually increases. That's a responder. At the same time, if we look at esophageal pressure, during inspiration, esophageal pressure decreases, and this is esophageal pressure at the end of expiration. With the introduction of neuromuscular blockers, you see a huge change in and expiratory pressure. I know if you see this picture for the first time, it will take you a little bit time to digest it, but this is how how a responder looks like. While in a non-responder, by definition, there's no change or even a decrease in end expiratory lung volume and no change in end expiratory pressure. And interestingly, from a clinical perspective, there appear to be no differences between the responders or non-responders. So what are the determinants for increased end expiratory lung index in the responders? Not age, not BMI, SOFA, not tidal volume, respiratory rate, or any other ventilator setting, not sedatives, but the dose of fentanyl. So the dose of fentanyl, the more fentanyl, the larger the change in end expiratory lung volume. And maybe we'd understand, because opioids increase expiratory muscle activity. And this is interesting as well. And it's complex, and I have -1 minute, so I'd go through it really fast. But actually what you see right here is the Campbell diagram of a non-responder and the Campbell diagram of a responder. And the responders use their expiratory muscles. And the non-responders do not use expiratory muscles. So how I would interpret this study, I think the effect of neuromuscular blockers on end expiratory lung volume are highly variable and unpredictable. And all clinicians will recognize that. I mean, in some patients, if you administer neuromuscular blockers, saturation goes down, while in other patients, arterial oxygen saturation goes up. And now we have a good physiological explanation. So the increase in end expiratory lung volume is related to relaxation of the expiratory muscles, and there's a linear association between the fentanyl dose and the increase in end expiratory lung volume. And this is my very last slide. So what I have learned from these 3 studies is that at this moment, I think we should avoid the routine use of extracorporeal CO2 removal in patients with acute exacerbation of COPD. Upon transition from OR to the ICU, keep an eye on the mechanical power. It has a large impact, and the effects of neuromuscular blockers on, for instance, oxygenation, although not really measured in the study, depend on whether the expiratory muscles are active during assisted ventilation. And obviously, the most important thing, you should always read the Blue Journal to keep updated.
Thank you very much, Leo. We have time for a couple of questions if you want. Question to Leo or question to the authors. I saw some of them in the room. I don't know if you have. Just maybe 2 points. The first study was called Vent Avoid, right?
Yes.
But it's Ecor Avoid, the conclusion.
Right, that's
so,
right.
Okay.
So the authors had different expectations, probably.
That's a bit of a joke. But the second study showing the transition to the OR to the ICU, is it maybe the first study showing a potentially detrimental effect of respiratory rate beside the theory and maybe the observational studies?
I think so, but we have to keep in mind that, I mean, most of these patients had, I think, relatively good compliance of the lung. And nice data from you and Gallagher have actually demonstrated that when elastance or compliance is normal, the impact of tidal volume on further lung injury is less. So that may be an explanation right here. That's right, yeah. But I was as an ICU doctor, I was a little bit shocked. I would think that we would do better than anesthesiologists, but that's quite disappointing, actually.
And my last point is for the last study, which, okay, so based on the dose of fentanyl, patients tend to use their expiratory muscle more. So they kind of react against the PEEP, right? They avoid the benefit, let's say the beneficial effect of PEEP on lung volume. They have a lower lung volume. So that would be the patients who benefit from an MBA in the...
That's right, yeah,
okay.
I think so, yeah.
Okay.
Yeah.
Okay, fantastic. Thank you so much, Leo. And our second speaker and editor is Ed Cheng from New York, who is going to discuss papers on sepsis.
All right. So I have to follow the wonderful physiologic papers because mine is a little bit drier. It's just epidemiology, but hopefully we'll have some fun going over some what I think are really outstanding papers. And so first of all, we're going to be looking at this pretty controversial question, but hopefully the results will make us all feel better about the practice of critical care medicine across the world. And that's this question of, has sepsis mortality really improved over time? And so a group led by Hannah Wunsch and Haley Prescott actually took advantage of temporal trends in mortality in critically ill patients with sepsis in the United Kingdom. And what they did, a really fascinating thing, is they used overlapping multi-cohort designs that spanned over 30 years, because there's this idea that maybe it's billing codes that are driving the change in sepsis mortality. It's the idea that we're letting in less sick patients to the ICU that's driving the change in sepsis mortality. Or it's or is it practice? Is it that we're giving antibiotics earlier? Is despite an older population or even more sick population that we're actually doing better because of sepsis recognition? And keep in mind, this is despite the fact that we haven't really had positive clinical trials over this time period. So how they set up this question was they used two cohorts, the Intensive Care Society's Apache 2 study, which is when NOSH released Apache 2 in the United States in 1985. Investigators across the world wanted to repeat whether or not Apache 2 had the similar prognostic ability in their own cohorts. And so the UK took a look at 26 ICUs and looked at their case mix and calculated the Apache 2 scores and banked away this data and the association with mortality in 1988 through 1990. And this is the UK Apache 2 study. And also the ICNARC database, also led by the same senior author, Kathy Rowan. Across the UK, they have 255 ICUs that continuously provides data, outlining all of the critical care practices that happen. And this involves over 400,000 patients that were identified with sepsis across the two cohorts. And they evaluated the relationship with sepsis and outcome in three ways. So they did an adjusted analysis. The adjusted analysis looks at patients across each site and across all the time periods. And they adjusted for age, site of infection, and the presence of 5 comorbid conditions. And they also did a matched analysis. So this was matching by age as opposed to just adjusting for age, site of infection, and 5 conditions that were present in each time period. So they did one-to-one matching across each time period. And they also did a very innovative thing, was they matched within the same ICUs across the same 30-year period, so ensuring that the patients were being cared for at the same institution. So let's look at the numbers for each one of these different analyses. You have the matched cohort on the left-hand side of the screen, where you have 700 patients in the 1988 group, and you have 6,000 patients in the ICNARC group over the longer time period with the bigger group. And then in the same ICU cohort, you have around 300 patients compared to 27,000 patients in the ICNARC group. And here are some of their results. So Apache 2 trends and age trends over time. As you can see that the age across time of patients admitted to the ICU was very variable, but there was a modest increase. And also the Apache 2 scores over time decreased. So the severity of illness, indeed, as people have argued over time, did go down. And if you look at the temporal mortality trends, you can see that, as you cross from the Apache 2 cohort, which is all the way on the left-hand side in A, this is completely unadjusted, you can see a curvilinear decrement in your mortality over time. And then at every analysis that they performed, if you look at the screen B, this is their adjusted analysis. Screen C, on the next page, we have our matched analysis. And then we have the same ICU analysis. So we see a negative slope in each one of these analyses. Whew, thank the Lord that we are getting better. When you quantitated this in the unadjusted way, going from a 54% mortality in 1988 to a 32% mortality in 2017, the adjusted absolute reduction was 8.8%. And of the total reduction, 60% was explained by change in case mix, whereas 40% of the total reduction was not explained by measured factors and may be the result of improvements in ICU management. There are residual questions. Your burden of urinary tract infections has gone up in more modern ICUs. They excluded surgical patients, so they didn't look at postoperative sepsis. And what constitutes a surgical patient in 1988 versus what constitutes a surgical patient in 2020 is a different thing, in part due to interventional radiology's ability and percutaneous management for source control, et cetera. So what leads to operative management is potentially different. And we don't have a sense of what is not admitted to the ICU. And so confounding by indication is not fully addressed, even if you address for case mixes. But this is good work to all the ICU researchers, and we were encouraged by this. Okay, next, by a French group, Grindeau and colleagues, does the effect of volume resuscitation vary with location? So this is a really fascinating systematic review where this group looked at country-level geoeconomic status and where, when a clinical trial, a randomized clinical trial that looks at the relationship between a conservative strategy, whatever that conservative strategy would be, and a liberal fluid resuscitative strategy, and seeing whether the geoeconomic status of the country would modify the outcomes related to this this endpoint. Because there was one-off studies here and there where potentially this influence might exist, but it was never been systematically studied. And so the study characteristics, they found 29 studies with over 11,000 patients where a higher versus a lower fluid resuscitative strategy was compared. And interestingly enough, this surprised me as an editor, almost half of them were performed in low and middle income countries. And the comparative analyses that were within all of these trials, they included trials with fluid bolus. In the higher group, this was usually 3.3 liters compared to 2.3 liters in the lower group. Cumulative fluid, 3.5 liters in your liberal group versus 2 liters in your conservative group, or fluid balance, which was higher in the liberal group versus the conservative group. And then here's the really interesting data, is that mortality varied by location. So the low middle income group, the forest plot is on the left-hand side of the screen, and you can see lower fluid volume was protective compared to higher fluid volume across all of the studies that were performed in the low middle income group. And in the high income group, the odds ratio for mortality was stone in the middle. But there was no effect in the high income group when stratified by location. And so they pursued potentially causes of this difference in mortality, and they looked specifically at whether or not some of this was mediated by when the trial was performed, whether the performing locations had the ability to support patients with mechanical ventilation. So if you look at locations of performance where there was some documentation where they did not have access to mechanical ventilation, you see the mortality difference related to conservative versus liberal fluid. But when you look at even low middle income countries together with high income countries where there is the ability to support patients, you see no difference. And moreover, the risk of new onset ventilation at the top of the screen, you can see the low income groups that we're able to support. As another interesting finding, that the low income groups that we're able to support for de novo mechanical ventilation, there was a risk that was not seen in the high income groups. So in conclusion, the effects of fluid resuscitation differed by setting. Higher fluid volumes or fluid resuscitation is associated with increased mortality in low and middle income countries and in settings with restricted access to mechanical ventilation. Precise reasons for these are unclear and may be attributable in part to resource constraint. Variation between the participants in clinical trial are unmeasured factors. So my takeaway from this is that it's a very provocative report, and it makes us think about whether or not our guidelines and our for surviving sepsis campaign, et cetera, should include a caveat in that your resuscitative strategy should be thought about with your ability to provide support. Obviously, it's just something to consider, and further research in this area must be performed. Because the effect of de novo ventilation makes us think that perhaps that the substrate of the patients who arrive in the low middle income countries may be in part driving this outcome. And lastly, I'm going to describe a question of, is there heterogeneity of treatment effect related to the timing of antibiotics? So this is a group out of University of Michigan, led by Haley Prescott again, so she has two papers in this group, but this one is also really fantastic. And this is the idea that we all think earlier time to antibiotics is better, but they asked a question of whether or not there was heterogeneity of treatment effect based on patient factors that would modify the association with time to antibiotics and outcome. And they did this in two cohorts, both the Veterans Administration cohort across the United States and Kaiser Permanente cohort in California. And they evaluated a dichotomous definition of time to antibiotics, where they saw less than 3 hours, which ended up being about half of the antibiotics in their total cohort were administered within 3 hours, so this was a midpoint, versus a longer time to antibiotics. And they evaluated this in three ways. They did a Poisson regression looking at the total factors individually and evaluated their association with the outcome of mortality related to the time to antibiotics. This is community-acquired sepsis. This is basically an ER-based study. They also did something called a causal forest, which goes beyond the scope of this talk for me to really describe what causal forest is, but it's a machine learning method that broke apart the groups based on a quantile. In this case, it was a quartile of the probability of heterogeneity of treatment effect, and they evaluated whether or not there was variation within each one of the factors in the groups across those quartiles. And I'll show you the interesting figure to explain this. And they also looked at logistic regression with time to antibiotics modeled as a spline as a continuous outcome additionally. So this was a very, very large cohort, over 200,000 patients with sepsis. And as I said, about half of them were in the short time to antibiotic groups. About half of them were in the longer time to antibiotic groups. Surprisingly, there were not that many differences in the shorter time to the longer time. However, if you had shock, it was more common to be in the shorter time to antibiotics. If you had a high lactate, that's that lactate variable there, you were more likely to be in the shorter time to antibiotics. But the distribution of comorbidities was kind of spread throughout. But the results of their Poisson regression analysis pointed to some very interesting findings, and that in the overall cohort, dichotomized less than 3 hours versus greater than 3 hours, there was only a 1% absolute mortality reduction associated with the earlier antibiotic. But this was not the same distributed throughout the patient characteristics. And I'll draw your attention to two conditions. One is if you had shock upon arrival, there was a 7% mortality reduction associated with earlier antibiotics compared to no shock. And if you had, is it on this slide? No, it's on the next slide. And if you had metastatic cancer, you had a 5% absolute mortality reduction. And you can see here the mortality reduction when broken down by age didn't really follow that much of a pattern. It actually peaked in midlife. So your mortality reduction based on different age kind of peaked at age 40 to 60 and then tended to go down from there. And so they followed up specifically with this causal forest analysis, and the top two most variable across the quartiles of potential benefit from earlier antibiotics, the highest variability was seen in comorbid metastatic cancer patients and shock. And so there was more of them present in the highest benefit group compared to in the lower benefit groups, and they had the highest variance. So this gets confirmed in the different analytic pathway that these two conditions seem to be more likely to benefit from the earlier antibiotics. And here is the logistic regression with splines over the continuous hour-by-hour analysis of the time to antibiotics as not the dichotomous outcome. And you can see the presence of shock is on the top, on the left-hand side of the screen, where you see the increase in your mortality in a curvilinear fashion compared to shock from no shock. And then metastatic cancer, there's almost a linear increase from time. So in conclusion, in patients with community-acquired sepsis, mortality benefit with shorter time to antibiotics varied by patient characteristics. Its findings suggest that shorter time to antibiotics for sepsis is particularly important among patients with cancer and or shock. I would say additional interpretative evaluations across these three studies, or this study in particular, is that there's still a role for incomplete control of confounding, or there is also the role that mortality, especially in patients with metastatic cancer, the attributable mortality fraction related to sepsis might not be equal across these patient characteristics. All right, thanks very much.
Thank you very much, Ed. Maybe just two comments. The fact that sepsis has improved, that's good news. But I would say it has improved despite the lack of positive clinical trials, right?
Yeah. So the authors really took an interesting approach to how they interpreted that result, and a lot of this was, potentially due to earlier recognition, resuscitation that we're not seeing in the pre-ICU period. So maybe this is our emergency medicine colleagues doing a better job of not letting patients languishing, or the fact that antibiotics are potentially given earlier in the course, or that we have more attention given to appropriate antibiotic therapy, appropriate timely source control, things that are not tested specifically in clinical trials, but could potentially improve overall mortality.
Yeah, there is a question from.
Hold on. Yeah, thanks. Just a very quick comment and then another quick comment. First, improvement of outcomes over time is, I think, what we see with all the studies. So we've done a bunch of N6, CTG, N6 core studies with the big database in Australia and New Zealand. And when we look at ARDS, it improves over the last 10 to 15 years. Sepsis. Tomorrow I'll show something about elderly patients. Their outcomes improve over the last 13 years. So everything we look at improves over time in intensive care. And I think it's very difficult to know what's driving that. And I think you made a very good point. But there's a whole bunch of unknowns. And I like to think myself that we improve outcomes by taking away some of the harmful things we used to do in the past. But I wanted to make a comment on the second study in terms of the explanation of this high versus low fluid strategy in lower middle income countries, because when Kat Maitland analyzed her study, it was not ventilation, it was cardiovascular collapse in the kids who were resuscitated versus the kids who were not resuscitated. And that was also in the other low income study, where patients who received more fluids then had more vasopressor requirement. So the fluid increased the need for vasopressors. We went to the lab and we published it in your journals about 5 or 6 years ago, I think, in the Blue Journal. And we showed exactly the same, that fluid resuscitation in sepsis increases vasopressor requirement, which is a very intriguing concept. There was a very good editorial accompanying it. And I think that's what we're looking at. I think in low and middle income environments, when you give a lot of fluid, you trigger more vasodilatation and cardiovascular instability, which is counterintuitive, but is supported by our data, our study, and that's the problem then, in terms of their resources and supporting these patients through that increased cardiovascular instability. I think that's the hypothesis that I would use, not ventilation. I think ventilation is not the cause.
That's a fantastic point, and I think thinking broadly about these topics is interesting. One of the reviewers sent to me, a average arm circumference of is lower in low middle income countries when they present with sepsis. The average albumin is 2, as opposed to 3 when they show up with sepsis. So there's a lot of factors that are potentially different, and so even third spacing of fluid and the transient nature that volume resuscitation could even increase cardiac output would be different. All right.
Thanks very much, Ed. Thank you. Okay, let's move on to the last part of this presentation, and I will talk about doing clinical research in the ICU. And so I'm going to describe a little bit of methods, which may be a bit dry, but please wait until the end, because I think I will show a fascinating result or summary. So you may have heard, I'm sure, that many people are now trying to use Bayesian analysis instead of the classical frequentist method. And this is a classical illustration where, let's say, the curve in the middle means the prior, which indicates that, so you have 3 curves, sorry. So the red curve would indicate the prior probability that something may work, but you don't know because you have equipoise and you can see you're close to the 0 line. And then you interpret your posterior result after the study as a posterior probability, which is much more intuitively interesting for us. Instead of saying 0.0056, no, it doesn't work. 0.0549, yes, it works. So there's a lot of appealing aspect of this technique, and you probably have heard about the reanalysis by a Bayesian method of the Eolia trial. This very large multi-center trial of ECMO versus non-ECMO. Such a difficult study to do, and we are not going to repeat it every 2 years, and which had a p-value I forgot of p007, and for many reasons there was really, it looked like a very strong signal, which was confirmed by the Bayesian analysis. So which was one example where there was some discrepancy between the Bayesian analysis and the classical frequentist analysis, which is not always the case. There are many situations where the two studies will show the same. So we had a kind of pro-con debate in the journal about Bayes and the evidence-based. And maybe the con was saying, are we going to analyze all the studies like that with many priors until we find a prior which is favorable to our analysis? And the response, in a way, in fact, was not definitely very pro-con with different opinion, was to say, yes, it's true. We have to be very careful with the prior. And one very interesting aspect of this paper is to provide recommendation, and for instance, saying we should avoid performing an unplanned secondary Bayesian analysis of your data if possible. Otherwise, every negative study will go to a new Bayesian analysis, and you need to think about your prior in advance. So it has to be clearly justified because it will impact on the posterior probability. So very interesting and important recommendation. In the same kind of reasoning, people are trying to use something else than survival versus mortality to describe potentially benefits of therapy in the ICU. Again, it comes from the fact that we have so many negative trials and we are a bit frustrated, and sometimes we say, yes, okay, there is not so much difference in mortality, but you have less patients who stay on invasive ventilation, less patients who develop a complication like a stroke, etc. And again, a really interesting paper which takes the example of one particular study which looked at hypothermia during VA ECMO, and the study was negative, and they used the study as a way to say maybe we can define some hypotheses. So we cannot really conclude things differently, but using the win ratio, which is the composite score with a hierarchy of the different outcomes. So let's say death is the worst outcome for sure. But then comes stroke, and then comes renal failure. So you define in advance, you make a score, you compare the two groups, and this can give you an advantage called by the win ratio. So another technique which may be, you may see more and more in the ICU to have a different way to do randomized clinical trial. And the last things we discussed, and again it's novelties in clinical trials, is the use of platform trials. I'm sure you've heard about it during COVID. Platform trials which were already implemented, and by platform trials I mean structure for doing continuously addressing clinical question, were ready to start very quickly with randomized clinical trial. And this is the example of steroid in COVID. Thanks to these platform trials, we had the response very quickly, and we have many examples. And we have been lucky enough to have a group of people doing platform trials in the world, putting together a paper and describing all these advantages, the practical, the Panther, the traits, INSEPT, and REMAP-CAP investigator, describing what are the advantages of the platform trials, which have many advantages, but are really, really heavy to build and needs a strong infrastructure. But once it's started, it should allow intensivists to have much more rapidly answer to new questions. And I like to finish by something which I think is really fun and exciting. So about clinical research and about the difficulty to do clinical research and about how long it takes to get final results. You may remember this study, the intensive insulin therapy in critically ill patients by Grit van der Berg. This was published in 2001. This has been one of the most influential study in ICU. A huge impact clinically. Grit van der Berg is an extraordinary researcher. She's here at this meeting. And she did two studies in Leuven showing this effect on mortality. Just be careful that the scale here is just it's significant, but it's not from 100% to 0%. But there was a significant effect on mortality if you control tightly the glucose. And I think it's only 8 years later that a new study, not performed by the group by Grit van der Berg, said, well, we tried to repeat the study in many ICU over the world, and including Australia, New Zealand, and Canada, and different places. And we could not replicate this result. We even found higher mortality with insulin therapy, and the reason was easy to understand, was more hypoglycemia. And so I think it feels bad, right? You have something which is studied very carefully, which show a reduction in mortality, and years later, you see the opposite. You may say, well, maybe it's the application at a large scale where it's more difficult to do and you have more side effects. So she really beautifully described in this paper what are the reasons for this discrepancy. And so this is the very schematic description of the mechanism by which hyperglycemia could induce damage to the organ. And in the paper, she described the mechanistic study, which really are very convincing, and whatever the final result had considerably increased our knowledge about this issue, and took a look back at one aspect of the management of this patient at that time, which is early parenteral nutrition. And early parenteral nutrition was recommended at that time. It was not used everywhere, but a number of places, including Leuven, were applying that as a way to try to improve patients' outcome by delivering nutrition and calories as early as possible. And just to make a very long story short, and this is a tour de force, which is really impressive. And I think this study has, yes, close to 10,000 patients. They repeated the study without early parenteral nutrition. So same studies, more or less same study than before, but now not using early parenteral nutrition in every patient. And you see here the blood glucose level in the control group, which is clearly different from the initial Leuven study, and also the need for insulin, which was much lower in the new study without early parenteral nutrition. So the new schema is a bit different because it adds now the early parenteral nutrition as a contributing factor to the hyperglycemia initially. And I think we have learned enormously about nutrition. I remember maybe 15, 20 years ago, there was not much enthusiasm about nutrition. We understand much better a number of things, and this clearly participated to this knowledge. So I wanted to show that because it's rare that you can really close the loop with contradictory studies or apparently contradictory studies and find the explanation for everything. So that's very impressive, and I really strongly recommend you to go through. Thank you very much. So happy to address questions, and I again see some authors in the room, so they may answer the question better than me. And just to say, we still have issue of the journal, so if you want, please, it's a free issue. Any question from the audience? Yes, Antonio.
I think I fully agree with Frank's comment that during the last years that we learn a lot is to prevent different treatments or, especially initial treatments to prevent treatments that can induce harm to the patients. So if you look on different trials and different new treatments are negative, but that we learn is that if we are doing much better our task as a physician, preventing the induced harm by the physicians, probably the results will be better.
Yeah, that's a very humble conclusion, but I think I agree. Leo?
I think it's an interesting comment, and to follow up on that, because we had a similar paper from the authors of the therapeutic hypothermia trials, right? I mean, we as clinicians based for the hypothermia on, I think, 2 small studies, adopted therapeutic hypothermia. We enthusiastically adopted tight glucose control. I mean, as clinicians, clinician scientists, what do we learn from this? I mean, if there's tomorrow another study that shows that, I don't know, selenium reduces mortality.
Really? Sorry.
Yes, it's confidential. Are we going to adopt this, or is there something that we have learned from this journey from hypothermia and tight glucose control that we, even if there's a paper in the New England, we should be a little bit more carefully in changing the clinical practice? And my first thought is, do we really understand the physiological rationale why a trial is positive or not? I mean, what do we learn as clinicians from these 2 journeys?
My recommendation would be to say, don't do guidelines every year. Please do it, because some people love guidelines, do it at least every 10 years. No, I don't know, but if you look at sepsis, the sepsis guidelines, they have changed many times over the years about tight glucose control, the volume of fluid, etc., all the things we noted. And I think we are doing a very poor job with guidelines. That's my conviction. Any other comments or? Okay, thank you very much for attending this session. Enjoyed reading the Blue Journal, this issue or the next one. Thank you very much.